I'm not sure. I'm not sure if we should wait a couple of minutes to give some more people to a chance to log in, but it is 4:30. And so maybe we'll just get through the introductions and those kinds of things first. I'm not sure how many we're supposed to have 69 or 59 people join, but I don't think we're close to that number yet. What do you think we should wait a little bit? We only have 15. Okay, let's give them 2 minutes or maybe until 25 too, and then we'll start. Good afternoon, everybody. I think we're going to start now. We are still waiting on a couple of people to join, but I think it's time for us to start now. Um, Thank you and welcome to the AGM for 2024. My name is Rushan and I've been asked to host. Can everybody hear me? Yes. Okay, cool. I've been asked to host this session, and so I welcome you all with the universal greeting of peace and love. And of course, I say love because this is exactly the reason why we've all given up our time to be here today. We all love what it is that we do, and we want to make an impact in the lives of those that we serve. So thank you for giving up your time. Today, the program will be the AGM, and so our chairperson, Dr. Gillian Saluji, will give the chairperson's report. We'll also have a financial report given by Dr. Jackie Bezuidenhout, and followed by a talk on palliative care by one of our colleagues, Dr. Louisa Murawambi. Yeah, sorry, sorry, Louisa. And then,
Okay.
sorry.
It's okay.
Oh, sorry, Mudawarima. That's it. Got it. Sorry. Okay, so she will be moderating the talk on palliative care, to do or taboo, after Gillian's report back. And then, of course, you can put any comments or questions in the chat, or you can unmute yourself at the end of the talk if you wanted to ask questions yourself. So I will hand over to Gillian, who will give us the chairperson's report. Thank you, Gillian.
Thanks so much, Roshan. I think you can all see the screen. Roshan is one of our co-opted members onto our executive committee, and I'm really grateful for your help. So I want to welcome you all. It's lovely seeing so many people here at the AGM. The AGM is usually maybe not the highlight of the year, but I think it's an opportunity for us to share what we are doing and what SA Child is about, and to share our activities with you, our plans as well. And we keep our AGM short and sharp, and hopefully share with you the highlights of what this organization is all about. So the agenda, as you've got, is going to, that we formally follow for an AGM, is that I haven't had any apologies. I will go through the chairperson's report. The treasurer, Jackie Bezuidenhout, will go through the treasurer's report. Then we've got the formal appointment of the auditor, election of the executive committee members, and then it's up to you, any other business that we haven't covered. The chairperson's report, I'll tell you about who the executive committee is, who our members are, what we do, and what we want to do. The current executive committee is myself as the chairperson. Louisa Mudawarima is our vice chairperson, Jackie Bezuidenhout, our treasurer. Then we have our members, Nico, Taekwondo, and Isaac. We had a number of resignations last year as people's terms came to an end. And so we co-opted some members onto our executive committee: Nick Smith, Carla Brown, Rashan, and Donna. The people with the red asterisk are people from outside South Africa. Part of our constitution says we are not a South African, we are Southern African. So we are really working hard to try and get more interest from people from outside of South Africa, which is why I'm particularly delighted that there's a team from Zimbabwe that will be presenting their work on palliative care today. And then we have Taekwondo, who is from Malawi, and we also include, as part of SA Child, is people with lived experience. So we have Nick Smith, who's a person with lived experience, and Dr. Mulati, who is a parent. What have our executive committee been up to? As you see, we had 4 co-opted members, and they really breathed new life into our organization. And I want to say a particular thank you to Nick Smith, who has really helped us to really craft and work out what is our message, what is our value offering, and what is our unique offering. And so that's what we have spent quite a lot of time working on over the past year. who are our members? You'll see in 2012 was the first year that we had members, and membership was free. So we had a fantastic number of members, but then we introduced membership fees. And so membership fees were introduced at the end of 2022. So there was a big gap between that should be 2021 and 2022. And that was because we don't have an automatic membership renewal, an automated membership renewals mechanism. People have to renew their membership each year. And then as we started introducing fees, so the membership dropped, but we are slowly picking up. Membership is open to people across Southern Africa, professionals and people with lived experience. And you can see our numbers are woefully low on that count. And that's what we are working really hard to do. So a lot of the work that we've done this year as SA Child is really to be clear about who we are, what do we do, and why should people be interested in being part of SA Child. So really crafting that message. If we want to attract members, we have to really be sure that members know what our organization can offer and does. So we're part of a global network that fosters interdisciplinary collaboration. And I think that's key, that we are, one of our unique offerings is that it's not discipline specific, it's across all disciplines, and also that we work, it's not just health professionals and not an us and we situation, but who we want to attract and include as members are people with lived experience, because we all have the same mission to improve the lives of individuals with childhood onset disability. How? How do we do that? We promote evidence-based practice. We want to make sure that what we as professionals offer is evidence-based, and what people with lived experience receive is the best care possible. And how do we do that is promoting research and collaboration. What is our unique offering? What makes us different to any other professional or parent organization? Is that we foster collaboration across disciplines, across regions, and most importantly, connecting professionals with people with lived experience. That we want to share our experiences. The experience you bring as a person with lived experience of a childhood onset disability or being a family member, that experience is what you bring. And the experience that professionals bring from their background and training. To working together to create a holistic approach to care, support, and ensure that all voices are heard, respected, and valued. So we are really strongly committed to making sure that that's what we do in all our activities. Why should you join SA Child? And I'm making this appeal because I think of the 59 or so people that registered for this webinar, I think only about 15 are members. So really saying to you, why not join us? And why should you join us? Well, through SA Child, you'll belong to the International Academy of Childhood Disability. So it's an access to a global network of professionals and people with lived experience, all who have a common goal, which is to improve the lives of people with childhood onset disabilities, and recognizing that a childhood onset disability is for lifelong. And so we want to have a look at and journey with people along the life course. We are committed to making research and best practices accessible and available to all professionals and people with lived experience and their family members. So by joining us, you'll extend your professional network, but also you'll be linked in with families. So what does SA Child offer to families and people with lived experience? It's a space where you can share your experiences, learn from others, and access valuable resources. And I think there are very few platforms where both professionals and people with lived experience come together to share the experience. Often it's an us and a them, the patient and the doctor. We're having none of that. This is a partnership where we are all working together with the same goal in mind, which is to contribute to a broader effort to improve the care and outcomes for individuals with childhood onset disabilities. I'm very aware that some people are now appreciate that, for example, Peter Dyke has been a very loyal member of SA Child for a number of years. So I think this should be nothing new, but what we have done as a bigger team is really honed in on this is what Child This is what SA Child is all about, and this is what we have to offer, and this is why we want people to join us and to work together in achieving our goals. So what is it that we do? Currently, we have three main activities. We host webinars, we conduct research, and we belong to the IACD. So the webinars are once a month, or sorry, usually about once every 6 weeks. And the webinar topics are chosen to appeal to all segments of our members. So there may be some topics that cut across all disciplines and have an appeal to both people with lived experience and professionals. So we look at topics that have broad appeal. We also have a look at topics that are maybe professional specific. And we also have a look at sessions where what we call listening and sharing sessions, where we want to hear and encourage the voices of people with lived experience. So since our financial year goes from March, 1st of March, end of February, but I've just put in all the webinars we've had since March last year, and you'll see this is what our attendance is, kind of, and what we want to really do is to make sure that everyone who attends our webinars also becomes a member. Our research activities, there are two main research projects that we are in. I'm the main investigator of the natural progression of motor development of individuals with cerebral palsy in low middle income countries. It's a longitudinal cohort study from childhood to adulthood. The data collection is complete, and we have done 2 international presentations on our initial data, which is on mortality. And this, I think, is really kind of pioneering work where for the first time we've got some idea of mortality and survival curves in a low middle income setting, combining what's happening in Bangladesh and what's happening in South Africa. So so the initial data coming out gives us something about, as I say, survival curves and mortality. And there was a presentation that I did to SA Child last year. So if you want to know more about it, you can just go to our webinar page and you'll be able to have a look at that webinar. And coming up, we'll be having a look at what has changed in the lives of children and how that's going to lead us to even more work. We really are identifying hidden problems of what happens as children get older. So that's the first activity. And the second activity, I'm going to hand over to Jackie, who's spearheading the second research activity that we are doing, which is the South African CP Register. Jackie, over to you.
Thanks, Gillian. Great. I'm sorry, I'm not sure if my camera is on. Can you hear me?
Yes, we can hear you.
Okay, super. Okay, great. So thanks so much, Gillian. Yes, we are very excited about the second research project, which is looking at establishing a SA Child CP register. We did send out a call to our members to say if you are interested in being part of the register to let us know. And we did have 67 members who have expressed interest. And so we are very grateful for the amount of enthusiasm that has been shown. Progress is being made, and we are currently in the process of finalizing the protocol. And once we've got the protocol approved and we have been through ethics, then the next step is that we're going to be looking to augment the existing GLM CPR data collection form with variables that are valid and pertinent to South Africa. And at that stage, we are going to be reaching out to you, our members, to say if there is anything that you feel should be included on the data collection form, we can then incorporate those variables as well. So we're looking at a timeline that is a little bit difficult to anticipate at this stage, but looking to see that the tool would hopefully be in some form of state to be rolled out in mid of next year. And just for those that haven't heard about the Global Low Middle Income Country CP Register, please go visit their website. They have a fantastic website that's got lots of resources available where you can look and see the research that they've been doing and a little bit more about what it means to be part of this global initiative of incorporating data from low middle income countries with regards to their CP individuals. So South Africa is next on the list to be incorporated into that, and so we're very excited to be using SA Child as the vehicle to drive this this new tool and program.
Thank you, Jackie. Something else that we gain from doing the research, well, not gain from, but where the research helps us, is that SA Child has got the structure in order to manage research funds. So we can manage funds, and from that we take a small percent to cover our admin fees. So it is also a source of income to SA Child. So it both enables the research to happen and also for us to be able to get a small income from it. Okay, so our third activity is belonging to the International Alliance of Academies of Childhood Disability. And there are a number of committees that we have representatives on: the Governing Council, the Executive Committee, the Global Professional Education Committee, Communications Committee, Conference Planning Committee, the Best Practice Committee, the Partnership Working Group, and the Research Committee. So we are represented on all those committees. So that means our voices as SA Child are being heard on those committees, but also there's a flow of information that through those committees, we are making a lot of global networks and global connections and being able to bring you, SA Child members, the very latest in what's happening in the field of childhood onset disability. One of the activities of the IACD is they have an annual global and listening sharing session, which is something that happens over a 24-hour period, where countries around the world each organize a session that's open to everyone. And the theme for this year's session is caring families, who cares for them. So look out for information about that. It will be at the end of November. The other thing that I'd like to tell you from the IACD is the conference next year, a massive international conference. Huge amounts of work has been done to it, been done in preparation for it. And what's exciting is that there's people with lived experience are part of the family users group that have had a strong influence on the design and content of the scientific program. So it really is going to be an international in all senses of the word. They have put a strong focus on low middle income countries and getting their voices heard. So through SA Child, we'll be sending you out lots of information about that. The abstracts, there's a call for abstracts, oral abstracts, which ends in October. And we'll also send out a link where the chairperson of this conference, who's put in the chairperson of the scientific committee, Professor Rainier Blanc, who came to see us last year, has put together a whole campaign about voices from around the world, where he's interviewed people with lived experience from around the world, and every week or every month they release some video. So we'll send you those links as well. So to Heidelberg, June next year. If you want to go to one conference in the year, I would really highly recommend this. Our plans for going forward is to drive our membership. We currently are sitting at 42. If we really want to make a significant difference, we could need a lot more than 42 people. We want to drive our membership both locally, but and really get much more involvement of people with lived experience. Part of our plan is to establish an advisory group so that we've got a greater network, so that we can reach out to a host of people that can support us if we are looking for as a resource, and to pulling in people with the expertise when and how they are needed. And our next project that we want to start is for youth and young adults with childhood onset disabilities who can connect. That's really come out of the natural progression study, that youth and young adults are socially isolated, particularly once they've left school. So we want to create a way and a platform for youth and young adults to connect virtually. I'm going to hand over to Jackie for the Treasurer's report.
Thanks, Gillian. Great. So just to start off, that we have got our annual financial statements from the 2022-2023 financial year. And so what you see on the screen here is just to give a quick summary as to the amount of revenue that came in 2023, which was 34,946. And in terms of our expenditure, we had 16,076 Rand, which left us with a surplus of 18,870 at the end of the 2023 financial year. Next slide. So this, what we've shown you here on the screenshot here, is just to say that if we look at our financial situation from the 2022 and 2021, where we were sitting in the deficits at the end of each year, we are now finally looking a little bit healthier from our financial point of view, and ending off with 18,000 in at the end of our 2023 financial year. Thanks, Gillian. So in terms of our sources of income, we have three main avenues. So the first is obviously the membership fees. And we have a tiered system of how we have different members paying for these fees, and I'll go through that in the following slides. We also do have some donations that have been given to SA Child. And then another source of income has been through our admin fee, which is from the research grants through the Cerebral Palsy Alliance. And they had put forward 987,142 Rand for the research that Gillian has presented. And of that, we have taken 3.5% as an admin fee. So which means for SA Child, there was an amount of 34,550 that was then put into our coffers, which was going to be utilized for the admin fees and the running of the websites and the Zoom platform, etc. So if we could just move on to the next slide, please, Gillian. Thank you. So looking at our financial position at the end of the financial year for 2023, we had a closing balance of 17,181. At the end of the financial year for this year, which was the end of the 23-24 financial year, our closing balance was 40,081 Rand. So it was a lot healthier at the beginning of this year. Currently, our balance is sitting at 31,485 Rand. So this is halfway through the 24-25 financial year. So things are looking a little bit more positive. And in terms of our expenses that we've had so far for this financial year, the annual deductions that we have, these include our website account, our Zoom license, our auditor fees, and then also the fees that we paid to the IAACD. So those amounts are there on the screen for you to look at. And then we also have monthly deductions. So we do pay our banking charges, and then also we have admin fees, which are 1,075 Rand a month for our administrator, who will then be monitoring the membership emails, sending out information, and putting together our webinars. In terms of our membership fees, so just to say that we currently, for our 24-25 financial year, have 44 members with 26 members paying, which brought in a revenue of 12,500 Rand, which is an improvement in terms of the numbers from last year, where we only had 32 members with 26 members paying. And just looking at the breakdown of these membership fees, if you are a member living in South Africa, it's 500 Rand. If you are outside of South Africa, it is 250 Rand. Our students also have a reduced rate of 250 Rand. And anyone with lived experience, whether it is yourself or the caregiver, there's no charge for those members. And we also do want to stress that if you would like to be a member of SA Child and you don't have the financial resources, we obviously will, we don't want to turn anyone away. So please just let us know if you are in that situation. Next slide, please. So this is our budget for the upcoming financial year. So this is projecting for the 2025-2026. What we did is we at the moment are sitting on our mid-August, so halfway through our 2024 financial year, we're sitting at about 31,000. We then look to see, with regards to our monthly deductions of our bank charges and our administrative fees, we project that in February 2025, we'll have our opening balance of 23,337 Rand. We are projecting, because we are being positive, that we are going to have more members join SA Child. And so we're projecting an amount of about 20,000 to come in from membership fees. And our total budget, excluding that which might be coming from research and from donations, is sitting at a healthy 43,337 Rand. When we then look at the the deductions that we are anticipating for 2025-2026, we are looking at 39,245 Rand, which would then give us a balance of 4,092 Rand for our projected 2025-2026 budget. I do want to just stress, in case you have possibly questioned, that we have presented the financial statements for the 2022-2023. The 2023-2024 financial statements are currently still with the auditor, and we should have them soon. And if anyone would like to see them before the next AGM, we will absolutely share those with our members so that you can see exactly what is happening. So we couldn't present those today because they weren't actually ready at this stage. So currently our balance that we are sitting at now in August is 31,000. So it's a good balance. We are our target is to increase our number of members. We would love to have 200 paying members. We'd love to have 100 members with lived experience at least. And we definitely would love to have more people from outside of South Africa joining SA Child and be members. So what we also wanted to just put forward to you as our members, that we would like to have a wish list as well. So some of the things that we brainstormed and thought about was that we would love to have an automated membership app so that it would make it easier for our members to renew their membership without having to go through the process of having to put in your details again. It also will help us to keep up to date as to who are the different categories of members so that we know who's paid and who doesn't need to pay. So that's one of our components of the wish list. We would love to, as Gillian mentioned, set up our WhatsApp discussion groups for our adolescents and young adults. And there we would like to have a facilitator or a social worker or psychologist who can then also help enable these discussion groups to happen with these individuals with lived experience. We would love to link SA Child with other organizations to increase our collaboration. We know that there are many different NGOs that are out there that are doing a similar job, although not the same, but we would love to link arms with Autism South Africa, the South African Disability Alliance, and just have sharing of information, sharing of webinars, and just making resources available. And sometimes there are membership fees that need to be paid for as well. So that was also part of our wish list. And then a big wish would be to have a travel grant for international conferences for SA Child members, especially those with lived experiences. So these are some of our items that we would like to have. We would love you to share what you would like. You can pop some ideas into the chat group as well. And then just from my side, just to say, if there's anyone that has any questions at this stage with regards to our financial statements or with our proposed budget for 2025, 2026, you're very welcome to ask questions either now or in the chat group.
Jackie, thank you very much for that. I know that we are going through the AGM at breakneck speed, but the chat group is there. Please, if you have any questions about something, or you want us to go back, or you want to query anything, put it in the chat, and we'll certainly keep an eye on that and answer that. Okay. I wanted to know if there were any questions around the budget, or if it's something that you, as who are members here, would be happy to say, yeah, that sounds reasonable. Go for it. Okay. And then a formal part of an AGM is the appointment of an auditor. This is MFS tax advisories have been currently our auditors and are willing to continue to do that, and I really have been grateful to them for their assistance. It is becoming a lot more work with all the research funds that have to be monitored and audited as well. So having a good auditor is absolutely essential. So I just wonder if we could have a formal proposer and seconder for that. Can just put it in the chat line. Thanks, Rashan. Thank you. Okay. All right. Then on to the next business. In terms of our constitution, our executive committee members have to be formally appointed at an AGM. We can co-opt members in between AGMs if and when we feel there's a need, and we certainly had to do that last year, where we had a number of members who had been with us for some time, for various reasons having to resign. So we've got 4 co-opted members: Nick Smith, Rashan, Sali, Donna, and Carla, who are co-opted. And if you remember, you would have received their CVs together with a motivation. So Nick is a person with lived experience. He's a teacher, an entrepreneur, public speaker, and he has really taken us to new places. Since we've really appreciated his expertise. He's based in Johannesburg. Rashan is a physio from Eros in Cape Town. Donna is a physio and also doing a PhD, so she's really connected to the academic world. And then Carla is the social worker at Red Cross Children's Hospital. And then I am delighted that Sherry Brainard has also been willing to stand as a member of our executive committee. Sherry is a person with Down syndrome. Her CV was sent out. She has a formidable CV of what she's achieved and a first in many areas as a person with Down syndrome. So it will be delighted that she's been willing to stand on our executive committee together with her mother, Suzette, who will help and be her facilitator. And then I'm also delighted that we have someone from Lusaka. We do need more people from outside of South Africa. So Musamba Kupapa. We don't have a maximum number of people that can serve on our committee. And as we are preparing and not preparing, we always need to have a long-term plan. So it is good to have a pool of people because it makes it easier for those people who have served for a number of years to leave because new people are there that have been grown and been part of the organization. So we would like to duly appoint these Nick, Rashan, Donna, Sherry, Carla, and Musambo to be members of our executive committee. And I say a very warm welcome to all of you. And with that, it's back to Rashan. Thank you.
Okay, so thank you, Gillian and Jackie, for that. We now go into our talk, which is finding an approach to palliative care and end-of-life issues for families of children with disabilities, especially in resource-limited settings. So Dr. Louisa Mudawarima will be the moderator, and the discussion will include a case presentation, which was managed by the palliative care team, and approaches to palliative care and life issues, like we said, and then, of course, identifying the resources in areas with limited services. And she will be accompanied by Agnes Chipo Tererai, who is a medical doctor and a palliative care specialist. Dr. Dixon Chifamba, who is researching pharmacological management of palliative care symptoms. Dr. Netsai Mujuru, who is a family physician and advocate for palliative care access. And then Mandizvidza, who is also general practitioner in the group of hospitals in Harare. Thank you, Dr. Louisa. Over to you.
Thank you, Rajan, and thank you, Gillian, and the rest of the team for, the enlightening presentation explaining what SA Child is about and the work that has been happening. I am going to share slides, and we have a shared presentation between Dr. Chifamba and myself, and then we're hoping to have a robust discussion about what's actually on the ground in the different places to help with palliative care of everyone, but also particularly focusing on children who have disabilities as well as adults who have childhood disabilities. Okay, so I have already been introduced, and my co-presenter is going to be Dr. Dixon Chifamba, who is a palliative care physician. And we're basically looking at a multidisciplinary approach to enhancing quality of life in individuals who have, long-standing disabilities. In this particular case, a child with dystonic cerebral palsy. So our patient's name is Anna. This is a pseudonym, and she is a 9-year-old girl who was seen in the presence of her mom. She had a pre-existing diagnosis of dystonic cerebral palsy, and I was asked to see because she required another admission by a pediatrician colleague. This was an evening admission. So when I went to see her, she had presented with swollen feet and weight loss. She had severe reflux, and she also had generalized dystonic spasms. She also had a history of constipation. So she had, as I alluded, a background of dystonic cerebral palsy that was secondary to neonatal jaundice and an associated pyrexial illness in the neonatal period. She had been experiencing feeding difficulty for an extended period, and this had culminated in the insertion of a feeding tube. She had an associated seizure disorder, and she had difficulty sleeping at night. She had a gastrostomy tube that was in place and was reported to be working well. However, the mom reported that they had to feed in small quantities because the reflux would be aggravated by large feed volumes. Her main caregiver was her mom, and the family was able to afford relief by a nurse aide several days of the week. But the mom was quite tearful during the initial evening consultation, and there were concerns about the well-being of dad as well. These were expressed by the mom. He was not there at the time of the initial presentation. And there was also a little bit of a discussion about how there was financial strain, and in order to get the relief that the family needed, they possibly, would struggle to get that sort of help financially. When Anna was examined, she was ill and unhappy. She had continuous spasms, and these were triggered by movement. And according to her mom, these were worse because this was a new environment that she wasn't used to. She was very wasted. She was pale. She had swelling of her feet. Her gastrostomy site was clean, and her systems examination was normal outside of those spasms that were continuous and the wasting that she had. So I was very concerned needed to continue managing difficulty sleeping, which was making things very difficult for the caregivers in the environment, and a family that was under duress. So initially, I managed the malnutrition. I increased medication doses as appropriate to try and reduce the spasms that she was experiencing. We managed the constipation, and we continued her anti-seizure medication. When I followed her up over the next couple of days, the caregiver continued to have concerns during the day. And the thing was that, everything felt like an emergency for the caregiver. And she was very stressed by the situation. We discussed the need for advanced care planning because this was a child who's had this condition for the last 9 years. She was severely wasted, and she was really, really struggling. And I needed to introduce the idea of asking a palliative care specialist to join the team. This was something that was initially, it initially caused some trepidation in the caregivers because, there's always this association with when you ask the palliative care team to come in, it means that death is at our doorstep, which is not actually true. What I recognized in this patient is that her her quality of life and the quality of life of her caregivers was not very good at the time that she was admitted. And this meant that we needed the expertise of people who will come in and try and help this family to find solutions for themselves for quality of life. And so I consulted Dr. Chifamba, who's going to continue with this presentation. So Dr. Chifamba, you can go ahead. I'm going to mute.
If you can help by moving the slides from your side. Thank you very much. Basically, what I'm going to delve into is the shared palliative care experience in the management of this child. Also to try and understand the role of palliative care in managing children with such diseases, and briefly talk or explore on the strategies for improving the quality of life for such children in a multidisciplinary approach. Next slide. Okay, I purposely put in my hand, ignore my poor handwriting, but it is just highlighting the initial assessment, which was in the hospital when we saw the child. And like what Louise pointed out, some of the physical aspects she's already pointed out, but on the psychosocial, what was interesting at that time, it was only the mother who was present. And the mother actually admitted that she was failing of late. She was failing to cope. And actually, she stated that family relationships had been affected by the illness of the child. And she also felt that the father was too distant, was not really committed, almost echoing what Louise said. And I think from her perspective, the father was actually avoiding the child. So the mother was actually, interestingly, was quite happy to have palliative care intervention. As you will see, the opposite when I encountered the father. Also of interest, all the spiritual aspects. The parents went to a different Pentecostal church. The paternal grandfathers to the child, grandparents to the child went to a different church, or one of the traditional churches, and also the maternal grandparents. So spiritually, there was actually quite a lot of conflict within the family in terms of interpretation of what this disease is, what was causing it. And the spiritual conflicts were actually straining the relationships within the family. Next slide. So after talking and counseling, we agreed with the mother of the child to have a family conference involving the father. And actually we set the time, and again, note that sometimes in palliative care, you are really called to do extraordinary things in terms of your coordination and timing. So we had to set this, although it was a weekend, but that was the only time the father was available. So we had to set at 11 o'clock to have a family conference. Next slide. In terms of the physical management, we just continued because that was being controlled. So the following day, when we had another conference with the father now was present, his understanding of the disease, he just interpreted it as a chronic disease of the brain. But he had high hopes. The child was going to improve. He was actually even thinking beyond. He was worried about the future, about the education of the child, and whether the child was ever going to get married. On the mother's side, like I said earlier, she understood the disease, maybe because she's the one who had been visiting the doctors most of the time with the child. And also she had obviously had high hopes that the child may improve, but she was not, I would say, 100% sure. So she had some doubts, which echoes with her understanding of the disease. So we discussed where to discuss, and they also asked me that we highlighted that the disease was a chronic, and from a medical evidence perspective, the chance of full recovery to normality was not expected. And we really had to communicate the bad news to the father and to the mother. And like what Louise said, it was quite difficult for the father to accept. Next slide. And the parents were, at the same time as we were discussing, the parents were worried why the child had malnutrition, which had already been stated, despite the fact that they were feeding. And from their perspective, they will try to feed every time the child. And we did discuss that this can be expected, a complication of cerebral palsy because of many challenges, and not necessarily due to the neglect, because they were feeling guilty. Parents also asked why was I now getting involved? And I think, Louise, thank you for that. You gave the background in the sense when she's actually we introduced, but it echoes a lot to this idea of palliative care. When does it starts? Because according to the parents, they said they actually thought my involvement meant the child was dying. And actually, I had to stress actually that palliative care starts actually at diagnosis. The father also on the social side highlighted the strained relations in the extended family, and also the understanding and the acceptance of that disease. And he actually stressed that from his side, they thought the disease actually can be helped spiritually by actually seeking help from the other alternative, if I may call, practitioners, the Nyangas and so on. So we had quite a long discussion, and at the end we agreed to have a further family conference involving both the maternal and the paternal grandparents of the child. And what is also interesting was that because of this illness, actually there was now conflict between the paternal and the maternal. Most of the paternal, like I stated, because they believed there was an element of bewitchment and may be coming from the mother's, the child's mother's side. We also discussed the advanced care planning, especially the issue of escalation of care, because at that time, the child was really in respiratory distress. And we discussed even issues of ventilating, because from the father's perspective, he wanted everything to be done, even including ventilation if it was really necessary. Interestingly, the mother, like I said, she had quite a lot of appreciation. Even she went to the extent that how long can a child with cerebral palsy survive on ventilation? And it was interesting that she asked that in front of the father. Anyway, we did counseling and we agreed to discharge the child and to support with home-based care. Next slide. Anyway, this is just briefly background. It's really just to show the need for palliative care. And some studies done, you can actually annually about 25 million children require, whether the newborns or babies or children, or even a teenager up to 19. So that's quite a massive. The question is, are they accessing that palliative care? And if we zero in the sub-Saharan Africa, you'll find that more than 7 million children need palliative care at the end of life. But nearly half of them who are in Africa, 90% of the children needing palliative care at the end of life. So there's quite a big burden of children who are needing palliative care, more so in the lower to medium income countries. Next slide. And interestingly, I mean, which relates to the question by the father. And sometimes when I've asked it, even when I'm called to see children, there's various understandings of palliative care. Some just think when you appear, it means the child is terminally ill. Some think, even among colleagues themselves, they think the same. Some, they only call you because to them, it's now care beyond cure, and that they may not be well equipped. That's only when we call palliative care practitioners. Some, interestingly, it's only when they are thinking of discharging the child home and coming the home care plan. So they think palliative care is only for home-based care, or when everything else has failed. Actually, some believe it's to make patients die peacefully and pain-free. And hence, relates very well when that father asked it and wanted to understand why the referral of palliative care was now. Did it mean the child was now dying? Next slide. I will not dwell a lot on the, I'm pretty sure a lot of us on this for well-versed the definition of palliative care for children, but just to stress that it actually starts when a child is diagnosed a life-limiting or life-threatening illness. And it continues whether or not there's treatment directed at that disease. Or even at this stage, despite the wealth of information shared in palliative care, whether it's the pediatric world or the adult world, you will see that even whether it's health professional lay people, they will still revert to the position where palliative care is only getting involved when the person is about to die. Next slide. Of course, this one is a more sort of consensus-based definition, a recent one through the International Association of Hospice and Palliative Care. I thought this is well encompassing in terms of defining palliative care, where it is the active holistic care of individuals across all ages. Very important. Yes, we know that young children are not young adults. They are children. So cross-cutting across all ages who have got serious health-related suffering, which can be due to any severe illnesses, and especially those, of course, near the end of life. And the main focus is to improve quality of life of the patients and the families, which sometimes in the health professionals training, the issue of also supporting the families and the caregivers. Sometimes I would say and admit we are not really well taught unless you go through a palliative care training. Next slide. Again, just to highlight, when I said children are not young adults, and what is actually for the pediatrician, it's actually, I always feel it's a more complex, because unlike in adults where you are dealing maybe with older patients and maybe the young adults, in the pediatric, it's quite a broad spectrum, which starts even when the baby is still in the uterus, the prenatal stage. Next slide. There can be complications, and especially in the recent developments where actually some babies have had operations in utero to address some of those challenges. And that become a challenge even for the pediatrician in navigating and in managing when we have got child, let's say we've got either congenital disabilities, the premature have their own challenges, and even those, when you classify children, even those they are young children, they are children 7 to 12, and they're going to be adolescents. All these have got their unique challenges in palliative care. Next slide. You can push up. I will not dwell a lot on these principles. Next slide, please. Next slide. Next slide. Okay, this is just to highlight the case which we are discussing today. I think the key principles of palliative care, it's very important. I think it's already with the picture which we are now already formulating, that early integration into care is very important. And the family-centered care. Not only for this particular case, but especially when you're dealing with child with a disability, and this can be quite varied. And the need for interdisciplinary team involvement should be key when you are practicing with children, especially whether the developmental challenges, disabilities. These three, I would say those are the key principles which every health professional or everyone who is supporting with a social worker or people chaplaincy, spiritual, they have to really embrace. The next slide. And if one is to ask where is the entry points for palliative care, to start that communication. And a lot of us sometimes we miss. It is very important that at diagnosis, and I think I cannot overemphasize that. But sometimes, let's say you'd missed it. There are sometimes when you see relapses happening or remissions, again, think about involving the palliative care practitioners, or if you decide to do elective cessation of curative treatment, it's an entry point even to start that difficult communication. And sometimes it's not necessarily to be done by the palliative care practitioners. Of course, they become quite focal, but any health professional, even with the basic minimum, can start that discussion so that by the time, even whether they are seen, it doesn't bring those anxieties like the father whom we are discussing today of the child. Then, if obviously when there's end of life, it is very important. Next slide. So, what is the role of palliative care in chronic conditions? We know children with chronic condition, including disabilities and life-limiting conditions, as the ones we are currently discussing, dystonic cerebral palsy. Palliative care plays quite a significant role. And it does not mean the end of life when you are involved, but it really talks about proactive and ongoing support needed for children with those long-term conditions. And whatever child's condition, they will need good care and support. And sometimes I always say, as health professionals more so, our default mode, especially maybe it's because of the training, it's to cure, and you miss this opportunity to give good care and support, or even initiating that critical discussions in terms of coming with the care plan. Next slide. So some of the challenges which we encounter, especially children with cerebral palsy and more so dystonic cerebral palsy, it really presents unique care challenges, especially in this particular child. The movement disorders and various drugs are being used to control these uncontrollable sort of movements which child had, but also the issue of terminal disease progression, to the extent that even when we started getting involved, it was really a challenge. Even when we asked those decisions about intubation, because there was actually contemplation that if the child deteriorates, the parents really wanted everything to be done. And children with cerebral palsy are at risk of neglect in that complex adult decision-making system. because they don't voice for themselves. It's usually the adults who make those decisions. And from our experience, palliative care is rarely sought, not only for the child, but even for the caregivers themselves. And what is interesting, if you look in the health system, I think maybe more so in the developing countries, it is actually totally sort of disregarded, the issue of palliative care, only when there are major complications, like in this particular case. So there's multiple unmet communication and medication needs stemming from a complex combination of these symptoms, which I've already referred to. Next slide. I'll just briefly, I'm not trying to make this into a medical lecture, but I've highlighted, I think for most cerebral palsy children, it is very complex to manage. The physical symptoms themselves, which I've already referred to, the pain management, and I cannot overemphasize this in the sense that the children cannot express their pain. And I'm imagining, if any of us, if you can imagine yourself, you are having even twitches or spasms, even if they're mild, worse if they're severe, how painful would they be? How would you manage? And how comfortable is everyone, whether it's the health professional, to start even, let's say, assume the child is in severe pain, to start even the appropriate medication, for example, opioids? It becomes quite a big challenge. Even the issue of feeding and nutritional challenges, which was also highlighted by Luis, the issue of inspiration and support, whether the family or the parents can consent to a feeding tube, especially when they have got high hopes that their child one day may improve. And if they see that putting a peg, which is a feeding tube, can actually hinder, according to them, the development, so that the child will become, actually I had one parent said, no, the child will become weak, may not now longer wanting to eat and so on. So they'll continue to foist food, and that can cause respiratory complications. Next slide. So the focus is really to enhance the quality of life. And we need additional multidisciplinary members in terms of the physical and occupational therapy, the speech therapists, and any mobility devices which may be necessary for those children. And the psychosocial support, which I've already mentioned, in terms of for those children who can understand, yes, equally important, but also more for the caregivers. The issue of ongoing support, or sometimes social work in terms of actually supporting, whether it's for the material side or issues which may be arising from within the family. Next slide. I've already talked about the multidisciplinary approach. I don't know how many I can without the risk of overemphasizing it. It is very important, and it should be done for coordination and managing the patients. And quite everyone is involved, from the social worker, the therapist, the chaplains, and everyone. The next slide. Let's not forget, in the process of management, which I also noted in this particular case, issue of ethical and cultural considerations, which I have already highlighted some of them. We need to address, even from a management, in terms of addressing these ethical dilemmas. Do you go ahead and intubate when you know that's the chances of surviving? And how do you engage the family? So it's quite difficult, the decision making. It can be quite complex in this particular case. And also balancing the issue of life, prolonging treatment with quality of life. I always say, who defines that? If the parents say, we need our child to be intubated, is it the doctor who refuses the ventilation? Is it the doctor who says, no, there's no need for repeated resuscitations? And again, we also have to be cultural sensitive in the management of these patients. And like I already highlighted, in the family already there were different, even from a spiritual perspective, understanding of the disease. Some wanted to consult other. When I discussed with the parents, actually, of course, they believed this was purely a medical condition which didn't need any other alternative therapist, so to speak, like ngangas and so on. And the care should be regular, including the communication. Next slide. Actually, as a conclusion from my side, it's more of a question: what are the future directions? Especially when you talk about cerebral palsy, more specifically, maybe in this particular dystonic, we know it's a complex and least understood. When you look at of the other cerebral of these movement disorders, there are other types, but all the same. And the discharged and home care planning is quite critical. And at this juncture, I will hand over back to Luis to maybe update us on the follow-ups which were done. Over to you, Luis.
Thank you, Dr. Chifamba. I was failing to find my audio button. So after having met with Dr. Chifamba, and I think particularly the greatest value for Anna was that the male caregiver was now brought fully on board to, what was going on with this patient, and the parents were now better able to make a decision about a way forward for the patient. So she stabilized over the next several days, and we were able to discharge her from hospital, and she was sent back under the care of her usual pediatrician. And like I mentioned, the parents were a lot more accepting of what was going on. And after several months, I got some feedback from the pediatrician who was looking after her, and she said that Anna had passed away peacefully at home, and the family had been well prepared, and they themselves felt very satisfied that the efforts that they had made in looking after her had been adequate, and that she hadn't wanted for anything, even though, she subsequently did pass away. And that is the end of our presentation. I'm going to ask the other members of our team to just quickly run through some of the, what is available on the ground in the different places with regards to palliative care, not just for children, but for adults as well. And, in general, not just in the context of disability. We can start with the Zimbabwean context and then move to other countries that are represented on the discussion.
Hi, Louise. Hello.
Hi, Dr. Guy.
Yes, can you hear me?
Yes, I can hear you. Please go ahead.
Okay, I'll briefly share. I'm at the airport, so I'm just distancing myself from the noise. So
Okay.
thank you very much for the presentation and for inviting us for this beautiful, I think it's a good kickstart for us to think, what can we do in our situation? So I'm just sharing briefly from the adults palliative care, which I'm more involved in. Once in a while, pediatric, but I think I'm like Dr. Chifamba said, the children, they just call my tears. They are more vulnerable for me. So from the adult side, even from the children in Zimbabwe, we have been trying through the ministry to integrate palliative care. So what we have is basically still mainly on paper in terms of policies. Some places they're a bit more progressed, like in Bulawayo, I think Natai can share about that. They Mpilo, I think they do have a palliative care team. So we hope that through these sharings and learnings, we can also come up even with the palliative care teams for especially our main referral hospitals, because that's where most of our patients, whether they're children or adults, are also referred to. And then we do have organizations like Island Hospice and some who are trying in small ways. But I think it's a call for us to have recognized structures for our people and for ourselves as carers, as health professionals. Thank you.
Thank you very much, Dr. Tererai. I see Dr. Mjuru, you're on the call. Dr. Natai Mjuru, please go ahead.
Thank you, Louisa. Thank you, Dixon, for that excellent presentation. I'm grateful to be here. Quite impressed with the presentation and all the areas that were or indicators for referral to palliative care. Repeated admissions, I think it's something as health professionals we should be aware of as a need for referral to palliative care, especially in children with or adults with chronic conditions that may not be necessarily life-limiting or immediately life-limiting. I think repeated admissions would be a trigger. And then also if you realize that there are information needs, which I think was clear in this particular patient that you discussed, that the family may not have, despite the child being 9 years old, may not have adequate information on the condition of the child. And then also it sounded to me like there was quite heightened family distress in this family. And that would also be a trigger to palliative referral, because the core of palliative really is communication, as Dr. Chifamba was repeatedly highlighted. Regarding palliative care services or provision in my setting, Chipo mentioned that we've got an integration program going on into the public health sector. The 2 tertiary hospitals in my setting have fairly active TC teams that cover the whole hospital, not just adults, but children as well. We also have rehabilitation center and school for children with various rehab technicians. Most of them are sort of college trained, not university, but they're very useful in rehabilitating children or looking after children with disabilities. So you'd have your speech therapists, occupational, and physiotherapists as well. I think being aware for health professionals, it's important to be aware of the resources that are there within your communities. So the social welfare, especially in our setting where family resources may actually be very limited, you find that sometimes you even just providing food, not just healthcare. So finding referrals to NGOs that can support the family, maybe with nutritional needs or school as well. Which brings me to, I think I didn't hear where the other children in this family are. That concerns me a bit, with the focus on this child who's been ill, obviously for quite a long time, with the other children in this family, with their needs being attended to, and to make sure that you correct, children sometimes think that they are to blame for what's going on in the family. So it's very important to be able to communicate with children at different ages regarding illness in the family. Those are my contributions. Thanks.
Thank you so much, Dr. Mjuru. And we also have Dr. Chigwedera on the line. Do you want to weigh in before I throw it out to others in the region?
Good evening, everyone. I think I didn't prepare much, but I just want to support what Dr. Chifamba, Dr. Terere, and Dr. Mjuru have mentioned. I'm based at Palliative Hospital, and I've been mostly working with cancer patients. Once in a while, you are called to assist a patient in the general ward. So I think the concept of palliative care involvement in the management of patients in the Harare setting is mostly limited to the cancer patients. We have to see the other cases like the renal, the neuro patients, the cardiac patients. So I think there's still a lot of room. We need to conscientize the practitioners. Also, the parents, they also need to be conscientized to know that when a palliative care practitioner is asked to be involved in the management of the child, it doesn't necessarily mean that the child is dying, because that's the biggest challenge that we face, that once you are called to see a patient, the mothers think their child is dying, and we need to get rid of that about palliative care.
Thank you. I'm going to ask others from the region to weigh in and just say, you know, what it's looking like in terms of palliative care, particularly in the context of disability in your different environments.
Hello, everyone. Is this for the audience? Are you just asking the audience, or?
Yes, for the audience. Hi, Jody.
Okay. Hi. Yeah, I'm Jody Wiles. I'm a pediatrician working in South Africa, in KZN at the moment, working general peds, but my love and background is children with disability and palliative care. So my clinic at the moment is the clinic that I do is with severe CP, and yeah, everything that was raised today is definitely applicable. I think just in terms of South Africa, I guess if you're thinking of the region, we're quite varied in how pediatric, I can really only speak for pediatric palliative care, is being implemented. I think I've previously worked in the specialist palliative care context in Cape Town, and that's where we were, the team, the specialist palliative care team was available to the tertiary hospital, and we were called with complex or specialist palliative care kind of cases. And then subsequently, I've moved to KZN, where our focus really is on integrating palliative care, like you've been describing. Yeah, and I think it's been quite a journey in the sense that although we do have the policy and we have a lot of advocacy that's been happening for many, many years. I think each province and each center is doing something slightly different. In our setting, we've worked on a palliative care integrated plan for the province, and we're currently training. Our next step is actually training little task teams for each facility in our public sector hospitals to be able to do general palliative care. Because I think that's really just going on what was said in the talk, that every person working with people, especially with life-limiting conditions, needs to have that skill and training in palliative care. So that's where we are at the moment, and it's actually quite exciting to see people sort of understanding more and more about what palliative care is, and your points about the starting a diagnosis and so forth has been so important, and especially in these children that we see with many symptoms and complex social situations. Starting those conversations early and the support early really does make a difference in the long run. So I can't speak for everyone in South Africa, but those are my two experiences just from two different provinces within South Africa.
Thank you, Jody. Does anyone else want to chime in? I would also like to invite any questions about the chairperson's presentation and the treasurer's presentation before I hand over to Roshan to wind down. Okay, it looks like we don't have any questions. Roshan, over to you.
Yeah, thank you. I would like to thank Louisa and the team from Zimbabwe for this very insightful and in-depth presentation. I know as a health professional, raising the topic of palliative care with parents evokes often many negative feelings. And I, for one, now have a better understanding of exactly what palliative care involves. And I can then take this forward to the parents that I deal with. So thank you very much for that. We don't seem to have any more questions or any more comments. Also, there are none in the chat. And nobody's asked any questions. So with that, I'd like to close the meeting. Thank you very much again to everybody who has joined us. My video was off. So thank you everybody again for joining us, making the time to listen to the presentations. If anybody has any further questions, feel free to email, check on the website, and email any of us with questions and concerns. Have a good evening, everybody.
Thank you.